Hey, podcast listeners, Fawaz Mufti here from Westchester Medical Center at New York Medical College, and this is another episode of the NCS podcast. So how awesome would it be to raise a wand and estimate the intracranial pressure without drilling a hole in someone's skull? Now imagine how terrific that would be in patients with elevated INR or severe traumatic brain injury who are generally very sick. I've always been fascinated with the optic nerve, more specifically the optic nerve sheath. The question is, how accurate is OSND? And how would the measurements vary between the hands of different practitioners? What is the area under the curve for the highest measured optic disc elevation to detect intracranial pressure greater than 22? Should you be training your fellows and APPs to measure OSND? And if so, can this ever be anything more than an adjunct to invasive intracranial pressure monitoring? Today you'll be listening to Dr. Krishna Rajajee from the University of Michigan on behalf of his co-authors discuss his recent publication entitled A Prospective Study of Optic Nerve Sheath Ultrasound for the Detection of Elevated Intracranial Pressure in Severe Traumatic Brain Injury that was published in Critical Care Medicine last December 2020. I hope you enjoy this episode.
Hi everyone, welcome to the Neurocritical Care Society podcast. I am Kassi Kronfeld. I'm a neurointensivist and stroke neurologist at Harbor UCLA Medical Center in Los Angeles, California.
I'm Jason Siegel. I'm a neurointensivist at the Mayo Clinic in Jacksonville, Florida.
And today we'll be discussing a recent paper published in Critical Care Medicine in December 2020 titled A Prospective Study of Optic Nerve Ultrasound for the Detection of Elevated Intracranial Pressure in Severe Traumatic Brain Injury. I would like to introduce one of the study's co-authors, Krishna Rajajee, who is a professor of neurology and neurosurgery, as well as medical director of the Neuro ICU at the University of Michigan in Ann Arbor. Welcome, Dr. Rajajee. Thank you for joining us.
Thank you so much for having me here.
I'd like to jump right in. So first, I was wondering if you could discuss how you became interested in performing optic nerve ultrasound in the setting of TBI, and what did we know about its utility prior to this publication?
Sure. So, the reason that I got interested in this was because I actually practiced critical care in India, for several years before moving to the University of Michigan, in a setting in which invasive intracranial pressure monitoring was really the exception rather than the rule. And we really had to manage patients all the time, using other measures. And so there was a tremendous interest in non-invasive techniques of intracranial pressure assessment, even if we could not, really quantify the ICP, just assessing high versus low, dangerously high versus not dangerous. And I think that's about the time that, the first reports started to come out about, this technique, about this ultrasound technique. I've always been very interested in critical care ultrasound, and so this was, I think, a natural fit for me back then. I think that, going back to how this technique first started to gain attention, it was, because, biologically it makes sense. The optic nerve sheath is just a continuation of the dura, which surrounds the brain and contains the subarachnoid space. So when your intracranial pressure is elevated, that ICP elevation is transmitted down the dura and down the optic nerve sheath and causes distension of the optic nerve sheath. And we've, always known this phenomenon through papilledema, because then the pressure pushes forward on the optic disc, distends the optic disc, and then we pick that up as papilledema. But the concept really is that your optic nerve sheath distends a lot faster and relaxes when your ICP goes down a lot faster than you see with the development and the resolution of papilledema. So that is a biological concept. There was, studies, I'd say really around the early 2000s that, started to show that this was biologically feasible, that this is something that was a real phenomenon. And then there were I think the earliest clinical studies in the mid 2000s, I would say, that started to show that this was something that might be a clinical tool.
Great, thank you for that great summary. I was wondering if you can briefly summarize the study design and execution of obtaining optic nerve ultrasound as it pertains to your study and the optic nerve sheath measurements. I noticed that you included both experienced and inexperienced providers in obtaining these images. And I was wondering if you could discuss a little bit more about why that was.
Sure. So, this study was focused on traumatic brain injury because we wanted to have a homogeneous population. And so this was a prospective observational study of diagnostic accuracy. The way that this study was conducted was in a neurotrauma ICU, and we would have the local investigators screen patients every day. So every severe traumatic brain injury would be screened. If the patient's family consented to participation in the study, then the local investigators who had a limited amount of training in performing this study would then go ahead and perform the study. The study would then be completely blinded. It would then be uploaded to a remote server where the ultrasound clip itself would be anonymized, and then the optic nerve sheath diameter would be measured by a remote investigator who was an expert in performing these studies. One of two experts would review these, would measure the optic nerve sheath diameter from the anonymized studies. Now, the reason that we did this was that we did require that the ONSD, the optic nerve sheath diameter, be accurately measured for this to be a valid study of diagnostic accuracy, and therefore the expert remote measurement served as the study that we used against the gold standard of invasive ICP. However, I think what we recognized was that most folks who perform an optic nerve ultrasound study today, and there are a lot of people performing optic nerve ultrasound studies out there today, really do not have the level of experience that a couple of our more experienced investigators did. And so given that ultrasound is extremely operator dependent and really requires training and experience, the question was, well, what if you provided more limited training to a bunch of individuals? Well, how would the accuracy, what would the inter-rater agreement be then? And so we felt like it was important for those providers to also measure the optic nerve sheath diameter as they would in clinical practice and commit themselves to a particular number. So that's the reason that we had these two separate measurements. The other reason that I didn't mention was that, this way we could completely blind the expert whose measurement we'd use in the study of diagnostic accuracy, completely blind them from every other detail of the patient, not just the ICP, but just the clinical details of the patient. And this is something we realized was important because we'd conducted other studies of ONSD measurement. I would be the expert investigator performing the ONSD measurement, and I might be blinded to the ICP at the time that I performed the study, but I would know the patient well. I would know the patient from the previous week on service, or I would even be on service. And I would know this was a traumatic brain injury patient whom I had struggled, to control the ICP, and I might have known what his ICP was just an hour prior to performing the study. And, I think that this is an important source of bias. When you know that the ICP is likely to be elevated or it is elevated, then I think you're likely to see the optic nerve sheath diameter very differently. And in our publication, we provide a sort of a photographic example of that, where with just very minor adjustments of the ultrasound probe, you can actually see and measure very different ONSD diameters.
Thank you for pointing that out. It is a skill obtaining the images alone and then knowing how to measure the actual sheath versus the nerve. So it was great to point this out in such a great graphic in the article. I noticed that you did an interim analysis for this purpose of validating the measurements and making sure they were done accurately. What were the issues that you were seeing as you were viewing the images that made you go back and, in a sense, retrain people to obtain these images properly? What were the common pitfalls that you noticed?
So what we did was that after the first 50 patients were enrolled, what we did was we performed an interim analysis comparing the expert's ONSD measurement to the point of care ONSD measurement performed by the less experienced investigators, and looked at the agreement between the measurements. And what we found was that when we did an initial interim analysis after 50 patients, the ICC the interclass correlation coefficient was extremely poor, was really, really poor. I think it was like 0.16, suggesting that despite the fact that when we got them off the ground and when they were initially performing the studies, everything seemed fine. Over time, there had been a sharp decay in their skills and their ability to accurately measure the ONSD. So I think what we noticed was that this video quality itself was okay because we'd instructed them to sweep the eyeball essentially from top to bottom. So all of the images that the expert needed to measure the ONSD was there in that video clip. But the point of care measurement was no longer being accurately performed. And this actually shouldn't be that surprising. If you look at the critical care ultrasound literature, you will find many examples of people reporting how easy it is to train novices to perform in a variety of studies, be it echo or lung ultrasound. But there's one interesting article that we quote in our publication, which also demonstrates that these you might be able to train them at first, but it's actually quite common to see this rapid decay in skills over a period of time. But I think the good news is that retraining can be effective. So when we saw this rapid decay, we actually went back and retrained all of the investigators, and that was actually had a more sustained, I think, impact. And for the remainder of the 70 patients who were enrolled in the study, I think we saw a much higher agreement. So we had an ICC of above 0.8 for the remainder of the studies.
Right. I think that was such a smart methodology to follow to really assess for that. And it sounds like the quality of the images was there, but really the measurements had that decay, as you noted, is a common pitfall. And it was great that it was corrected at the end of the paper. As we'll get into, it seems like that inter-rater reliability became much better. So I was wondering if we could move ahead and if you can discuss a little bit about why you chose the therapeutic intensity level as one of the outcome measures, and tell us a little bit more about this and how you applied that to the study.
So I think the reason for that was that speaking with clinicians, speaking with other clinicians, one of the criticisms of measuring the ONSD was, well, sure, you're seeing and you might be detecting or not detecting an increase in ICP now, but this could just be because the patient is bucking the ventilator, has just been moved, and this is really just a transient elevation in ICP. Why is this clinically significant? Really an ONSD or an ICP elevation rather is really significant to the extent that it needs to be treated. And so how do you really assess an outcome that incorporates the treatment necessary to control intracranial pressure? And really that is the therapeutic intensity level, which is specified by the NINDS common data elements for severe traumatic brain injury. And it's a score that's fairly easy to calculate. So every day, the local investigators would total up the therapeutic interventions applied to ICP control for each patient. I think that an important outcome was whether that patient required a high therapeutic intensity for the control of ICP. So a TIL summary score of 10. The reason this is important is if you think of where ONSD measurement might actually be used, I think it's going to be less useful in a fully equipped academic level 3 trauma center. I think that where it's likely to be more useful is in triage of patients at more resource constrained settings or at smaller centers where you're trying to identify the patient who needs to be urgently moved somewhere else. And if I think that the most important decision point there is this person likely to require more advanced management that we cannot provide? And I think that this is particularly true outside high-income nations, because in high-income countries, I think we take invasive monitoring for granted. But if you look at where non-invasive monitoring is most likely to be applied, in this fashion, it's actually the majority of TBI which exists outside high-income countries. This is the kind of setting that I practiced in many years ago, and so we thought that it was important then to identify patients who were most likely to require advanced management and potentially something like a decompressive craniectomy.
Great. Thank you for summarizing that. Moving forward to talking about the patients that you did include in the study, I was wondering if you could just talk a bit about the inclusion criteria. The study specifically was looking at severe TBI. And I was wondering if you could comment as well. It sounded like out of the 858 patients that were screened for the study, only 135 met this inclusion criteria. I was wondering if you noticed any trends there as to why patients were being excluded to get this number, and was this a number that you expected to be able to power the study?
So we actually had hoped for a larger number. We had hoped for about 250 patients, really. And we had certainly hoped, I think this is maybe a common theme, for a lot of studies, certainly for studies that I've been part of, where your recruitment and enrollment is not as brisk as you would, hope for. I think we were satisfied in the end. I think that a lot of patients just were not eligible, for a variety of reasons. And I think if you look at our eligibility criteria, it seems that it's not that restrictive, because really all we required was that the patient have severe traumatic brain injury, was expected to survive for at least 48 hours, not having any injury to the globe. But I think that one important exclusion criterion that I think led to a lot of exclusions was that they had to not reach that TIL summary score of 10 before the first ONSD assessment could be performed. So, there's logistical limitations. As you know, when we talk about research enrollment, this is often difficult to accomplish sometimes in the middle of the night, particularly for an observational study like this as against, clinical trial. And so by the time the research team is able to get in the morning, it's not that uncommon that the patient's already undergone, I think most commonly, a decompressive craniectomy. So the patient is rushed into the OR from the emergency department to undergo hematoma evacuation, and very often that's coupled with a decompressive craniectomy. And so then your initial TIL summary score immediately crosses 10, and you're no longer eligible for inclusion in the study.
If you could just go over kind of in general the major findings and how they could be applicable, as you said, to different hospital settings.
So, I think before I actually give you the findings, I just want to preface it by saying that I think it was important to, before we actually completed the study, specify in advance what thresholds of diagnostic accuracy would be acceptable. And that a priori specification, I think, in the end should always inform your conclusions. So, but if we just get to the results, in the end, we enrolled 120 patients. We already talked about how the ICC, the intraclass correlation coefficient, was initially poor but improved with retraining. But in the end, for the primary analysis, which was the ability to detect an ICP greater than the Brain Trauma Foundation specified threshold of 22 millimeters of mercury, on the face of it, it was really not that bad. Because if you measure that with the area under the curve, the AUC was about 0.81, with a confidence interval that ranged from 0.73 to 0.87, which is not bad. But then the optimal sensitivity that we were able to achieve was about 82%, with a very wide confidence interval. And the optimal specificity was 79%. Now, a priori, we had said, well, look, where is this ONSD measurement likely to be used? It's likely to be used as a screening test to detect patients who are better candidates for invasive ICP monitoring. Nobody really felt like the ONSD measurement could completely replace invasive monitoring. And so if we are going to employ this as a screening test, what is most important is sensitivity, because you really don't want to miss the TBI patient who really has elevated ICP. You misclassify them as not having elevated ICP. Don't place an invasive monitor, or don't move them away, or don't initiate aggressive therapy, and then an hour later they herniate. So that by far is the error that we want to minimize in a screening, non-invasive, easily performed screening test such as this one. So we set two thresholds. One was we asked people, well, what is the optimal sensitivity and specificity that you would like, if you had a test, a dream test. And so what they said was we needed a sensitivity of at least 98%, a specificity of 80%. And we knew that was, potentially going to be difficult to achieve. So we said, well, what is the minimum acceptable sensitivity and specificity that you would accept in a screening test like this? And they said, well, okay, the sensitivity still needs to be high, so less than 90%. And the specificity, we can't completely get rid of that, because if your specificity is just coin toss, then, why perform a test? I think that at that point, just your regular clinical assessments, your CT scan, that might be just fine. So they said something at least a little bit better than coin toss, so specificity of about 60%. And so in the end, the optimal sensitivity and the specificity that we achieved, it didn't hit those thresholds. So the sensitivity was certainly under 90%. And if you say, well, what's wrong with, with 82%? The problem with that is approximately 1 in 5 patients then who really have an ICP elevation, you're not going to detect with the screening test. And I think most of us will feel like that's just not good enough. 1 in 5 patients who are likely to, potentially even herniate because your screening test was wrong, to us is an error beyond that which we would consider acceptable. An additional component to that is, and you have to actually go to the supplementary table to see this, is that although we focused on the sensitivity and the specificity, the positive predictive value of an elevated ONSD was extremely poor. The majority of patients who had a high ONSD really did not have elevated ICP. And so this becomes a real problem, because at this point you really have to ask yourself if what you're doing is likely to outperform standard clinical assessments. And in reality, you have to say that it probably will not, which is also the case with the other outcome measurements. Or rather, really, it was worse for the other outcome measurements, where the therapeutic intensity level, the ONSD simply did not predict a high therapeutic intensity level and didn't predict other things like mortality.
So going back to the goal user of this, of this paper, the goal hospital, the goal ICU, who find this most interesting, how do you think not achieving those goals could affect them in their decision making, as you said, to maybe transfer to a higher level facility or not?
So my recommendation, and keep in mind also that I was an enthusiast. I was especially coming from a setting that I felt the need for something like this. I started off as an enthusiast. My recommendation for the folks who are doing this out there is you should not use the optic nerve sheath diameter in routine clinical practice to make those decisions. Because I just don't feel like that, we've managed to prove that doing so is going to outperform just routine clinical assessment. Obviously, I think that the ideal way to demonstrate that would be a randomized clinical trial in which one arm is assigned the diagnostic test and the interventions that follow, and the other is, you do that with your standard measurement, something like best strip. But there's no way that based on these results, I think that at least I would justify a randomized control trial. So my recommendation, I think, for the target person who might use this is, I think we should not. I think that, this is why evidence-based medicine is important, that I think that even though a diagnostic tool appears to be, useful, appears to be convenient and just makes perfect sense, doesn't necessarily mean that it's going to be the right thing to do. So my recommendation would really be that at this point we should actively explore other options for non-invasive monitoring. And, I would not routinely use the ONSD. Now, maybe there's exceptional situations where you might be forced to use something like this, but I think that I certainly would not use it routinely.
One of the findings I thought was interesting is that you guys found that the optimum threshold for your area under the curve was 0.72 centimeters. And it's been previously reported that 0.5 centimeters, 0.57 centimeters were optimum in distinguishing an ICP of 22 millimeters of mercury or higher. What do you think accounts for that difference between 0.5 or 0.75 and then 0.72 that you guys found?
So, we conducted a study of ONSD several years ago, and the optimal threshold that we came up with then was considerably different from, the one that we found in this trial. Thinking back on that, I think that the more accurate number is this one. But I think if you look at some of the CT studies of severe traumatic brain injury, because you can measure the ONSD on a non-contrast CT, and that might be subject to less operator dependence than an ultrasound, those ONSDs tend to generally be higher than those that you detect using ultrasound. So I think that this is probably closer to the accurate number. I think the reason that we saw the difference is just more experience. And I think that if you look at our methods, we were very specific about the criteria to measure the ONSD. And I think that was in part a reason for the poor agreement with the initial studies, and that we really were particular that you clearly define the optic nerve sheet, that you see the optic nerve, and then you clearly see the optic nerve sheet on either side of the optic nerve before you measure. And I think if you consistently do that, you're going to see, a higher ONSD. And again, if you go back to that image that you had pulled up a little while ago, if you don't do that, if all you do is take a linear hypoechoic structure and measure it, then it's quite likely that you're not going to be measuring the true optic nerve sheet, that you're going to be getting some sort of cross section of the optic nerve and part of the optic nerve sheet, and just measuring that. And my suspicion is because we were not as rigorous about the quality of the study in past studies, at least the ones that we conducted in the past. I think that the numbers that we saw then were significantly lower, because I think a lot of the time you were really not measuring the entire optic nerve sheet. So I think that's the reason for the difference. I think the fact that your optimal ONSD was fairly different between studies over the years has always been a little bit of a red flag and a reason to say, well, what ONSD should we really use? And I think that that's one of the reasons that in our methodology, we were so particular about the quality of the study.
Are there any thoughts on the horizon from you, your colleagues, or anybody else in the field as to how to make this technique more reproducible and more consistent between users, particularly at the bedside where people may not have years and years of experience?
So I think that going into the study, we felt like maybe a good solution to that was just automated measurement, that the machine uses an algorithm to measure the optic nerve sheet diameter. And in fact, more recently, we actually published an article that demonstrates that this is actually quite feasible, and that you can achieve a very high level of agreement between an algorithm measuring the ONSD, computer algorithm measuring the ONSD, and an expert measuring the ONSD. And in fact, in that study, there was a pretty good agreement between two experts measuring the ONSD. I will say that now I'm a little hesitant to say that that is the clinical solution. I think that's definitely the solution to addressing the lack of agreement between inexperienced and experienced operators. But I think if you look at our study, even the experienced operators, the ONSD measured by the experienced operators, didn't perform as well as we would like against invasive ICP. So I'm not sure if just consistent measure of the ONSD will in itself solve the problem. I think that it's a useful thing, but I don't think it'll necessarily solve the problem. I think it's a useful thing as a first step to other ways of looking at this phenomenon. So, for example, there's been publications of the eyeball to ONST ratio. That the reason that the ONST is not really as predictive as all that is because people are of different sizes, and that you need to individualize the optimal ONST to the person. And one very simple, almost simplistic way of doing that is to look at the ratio of the diameter of the eyeball to the diameter of the ONST. And I think if you pair something like that with a consistent way to measure the ONST, consistent and accurate way to measure the ONST, that's possibly going to have greater significance. And the other thing, of course, that we found in our study was the optic disc elevation, which is sort of the precursor to papilledema, which we know, is something that often reflects high ICP. It's just not particularly sensitive or specific. The optic disc elevation is the extent to which the optic disc is pushed forward into the retina, bulges into the retina rather. And at least in our study, it seemed to achieve greater diagnostic accuracy than measurement of the ONST itself. But I think the important thing is to caution anyone listening to this or reading the paper that this is a very preliminary finding, and that especially given what we've experienced with ONST over the years, I wouldn't jump to using something like this in clinical practice. But I think it does offer a useful thing to look at for other people to look at and to perform larger studies on.
Thank you, Dr. Rajajee, for giving us a very expert and evidence-based review of the utility of optic nerve sheath diameter ultrasound measurement, especially in the management of severe TBI. We really appreciate you joining us, and thank you to the NCS podcast listeners out there for joining us today as well. Hope you enjoyed this discussion.
Thank you.
With continuously updated content on topics ranging from acute ischemic stroke to clinical evaluation of coma and brain death, prognostic assessment, and traumatic spinal cord injury, Neurocritical Care On Call is the only product of its kind to offer content exclusively dedicated to the practice of neurocritical care. This interactive, subscription-based website features tables and figures, videos, author insights, and sections specific to nursing, pharmacists, and APPs. To learn more about subscribing to Neurocritical Care On Call, visit www.neurocriticalcare.org/on-call. Use promo code PODCAST for an extra 10% off your subscription.
Thanks for listening to the NCS podcast. The NCS podcast is produced by the Neurocritical Care Society, whose mission is to promote quality patient care, professional collaboration, research, training, education, and advocacy in neurocritical care. Our production staff includes Tariq El-Maghribi, Andrew Barishmet, Leonid Groisman, Atul Kalanuria, Lauren Kaufman, Kassi Kronfeld, Holly Ledyard, Lindsay Marchetti, Alexander Reynolds, Lucia Rivera-Lara, John Rosenberg, Jason Siegel, Zachary Threkold, Teddy Yoon, and Chris Zaman. Our administrative staff and senior producers Bronnie Rousseau. Music by Mohan Kadapali from the University of Miami Division of Neurocritical Care. If you like our show and want to learn more about us, check us out on Twitter, Facebook, or LinkedIn. The NCS podcast is available on NCS On Demand, iTunes, and wherever you get your podcasts. I'm Fawaz Al-Mufti, and thanks for listening.